right. We are live on YouTube and live on Facebook for today's Sunday social. And I know that I am super early. I've been starting to do the Sunday socials earlier now just because I don't have a lot going on uh, in the middle of the day. So I've been doing Sunday socials earlier. So I just wanted to say welcome to all the new members to the YouTube channel and to the Facebook group. Welcome to Sunday Social. For those of you who are new, Sunday Social is a live stream on Sunday evenings or Sunday at some time where I just talk about the exam, answer questions about social work in general, and discuss just any kind of current topics or whatever people send me to talk about as far as social work goes. So I will not plan to keep everybody long. I see a few people are here on the YouTube channel. If you could tell me where you are viewing from, what city and state, I would appreciate it so I can see who we're reaching out to. But welcome again, send your city and state in the live chat so I can see where you're from. Don't have a whole lot going on this week. I think last week was a short week because I had Monday off. I think a lot of people had Monday off for Labor Day, but we'll be going full swing next week or this coming week. So, someone asked me to talk about documentation and self disclosure. So, that's going to be the topic for tonight. It's not going to be a very long live. So, documentation, and we're just jumping right into it because, I know a lot of people don't want to hear me blabbling on about other stuff. But anyway, so we're going to talk about documentation. Documentation is very important, of course, in our field because if you didn't write it, it didn't happen. That was instilled in me, from the very beginning as a social worker. If you didn't write it, it didn't happen. But just because you wrote it doesn't mean that it's true. So make sure your documentation is accurate and that you're not making up stuff, which I mean that goes unsaid because we're all adults and professionals and we have character and integrity and all this other stuff. So um, I guess the main thing that I can say about documentation is hi Arnetta Williams from Madonna, Georgia. The main thing I can say about documentation is when I very first started out as a social worker, back as a professional social worker, meaning I had earned my bachelor's degree by that point. I worked at the domestic violence shelter, and it was my first time ever knowing about audits and knowing about charts and documentation and all this kind of stuff. I was clueless. So they told us that we were being audited, and I had no clue what that really meant. So the auditor came, and she was like this militant kind of lady who she had a nice little smile on her face, but you could tell that she was not there to play. And so she got my charts, and I was so nervous because they told us what she would be looking for. And, we didn't know that she was coming until like the day before. And so she did a home visit with me, and she did an audit of my charts. And so as she was looking through my charts, she was very silent, and I was just kind of sitting there. So then she pointed out to me something that did not match up. And so she wanted me to explain why it didn't match up. And so I said, well, I try to write down everything that happened. And she stopped me and she said, you don't try, you do. And from that point on, literally, I write every single thing down to the detail, verbatim, pretty much ever since then, because that just really stuck with me. She said, you don't try, you do. You write down everything that happened. And that has stuck with me. So even on my current job, my documentation is like pristine. Like I write down the exact date, the exact time. You don't have to be that anal about it, but I do write down the exact date, the exact time that I made phone calls, because I want things to match up. Like if they ever wonder, well, did you really call this lady on January 8th at 10:49 p.m.? They can pull out my work cell and look in the call log or pull their records or whatever and see at that exact time that I made this call. I don't put, how long I stayed on the call, unless the call is like an hour long or something like that, then I will. But, I put down who was present Like if I have to go to a home visit or an office visit, I put down who was present at the visit. So professionally, was it me and my nurse that I worked with, or was it another colleague? Were there other social workers, the provider? On a home visit, if more than just the patient is there or the client is there, I will put that the mother and father were present. I put names. I will say try on this. I try to put names because some people don't tell you their name and you just don't get it. But if I know the relationship to someone, to the patient or the client, I'll put who that person is. Because what I've noticed in our electronic medical record at the hospital system that I work for, some people will put their notes in and they'll say that the patient was present with the grandmother. Then they send a consultation to the social worker, me, and want me to call the grandmother, but they don't put the grandmother's name. And so I'm looking throughout the chart trying to find out a name, because I hate calling somewhere and not having a name to ask for when they answer the phone. So I would end up having to say, well, I'm looking to speak to the grandmother of Ashley Hart. Doesn't really sound good to say that, so I would prefer to have a name instead of just saying I'm looking to speak to the parent or guardian or the grandmother of the patient, because it doesn't look like you know what you're doing. It doesn't look like you are on point with knowing what's going on in the case. So I personally like to put people's names along with the relationship to the patient in my documentation, because whoever comes after me, I don't want it to be difficult for them to know who they're looking for or who they're talking to. So I definitely put the names of people around or in the home. I always try to put how the patient is, their disposition, their demeanor. So if a patient is visibly distraught, or if they seem like they might be a little psychotic, or if they seem like they have a flat affect, or if they are sad, or even if they're happy and they're talkative and they're energetic, I put all of those descriptors in my documentation, because it kind of helps, especially if you see the patient or the client on an ongoing basis. It kind of gives you a baseline of how this client's demeanor and disposition is. So, if you have 5 notes where the patient is depressed or anxious and moody or whatever, and then on the 6th note you notice that the patient is happy, and the 7th note they're happy. So then you can follow trends of what happened. So maybe the first 5 notes where they were kind of depressed, you recognize that they had symptoms or signs of depression, and you got them help in the form of counseling or whatever. And then they started going to the counseling. And then by the 6th and 7th session, their mood improved, because maybe they saw a psychiatrist, maybe they saw a social worker for therapy, maybe they started medication or whatever. And so then their mood started to change. But then you might see, in later appointments that their mood changed again. So then you want to know, well, are they still going to counseling? Are they still taking this medication? So I always document how the patient is as far as their mood and their affects. What else do I put? I had it in my mind. Where's my pen? I need to take notes. I always put the mood, the affects, who was present. Gosh, I should have written this down. I thought I could remember it. My memory is not serving me well right now. I also put, oh, this is not good. I completely forgot. Anyway, so just make sure you document everything as it is oh, that's what it is. This is going to really irk me if I didn't remember it. So quotations, so direct quotes from the patient or the client. I always put direct quotes from the patient or the client, because it's very helpful to know what someone said. Now, if it's just general conversation and, if it's nothing profound, then I won't put direct quotes. But if the patient said, I don't want that creepy man touching me. Oh, I'm just talking about my grandfather. That's something that a patient said last week. And I was like, what? So, I make note of that, because that's not normal for somebody to say, I don't want that creepy man talking to me or touching me. oh, that's just my grandfather. That's something that should be concerning. That's something that should shoot up a red flag. If a patient or client says something like, you know, my dad is always home except at nighttime when I'm sleeping, and the patient is 10 years old, and the dad is the primary caregiver and has physical permanent custody of the child, and the child says that they're at home by themselves. Like that's quotation worthy, because this is something that the child said out of their mouth, and we need to look into that. Also, making sure that all of your documentation adds up is also great in case your files or your notes or your charts are subpoenaed for court records. So it's nothing worse, and that's never happened to me, but there would probably be nothing worse than having your chart subpoenaed for court and your documentation is not on point, and you're asked to explain something and you don't even know what you're talking about. So they always say, document your notes as if you want the person behind you to have a clear picture of what's going on with the client or the patient. And they always say document your notes so that if you were subpoenaed to court, you would know what you're talking about, because a lot of us have high caseloads and we deal with a lot of people, and there's a lot of stuff going on in all of these people's lives. And so you kind of get stuff jumbled up. So it's good to have a good record of what happened and when, and having things to line up. So that's that on the documentation. I don't think there was anything more I wanted to say on that. But, if you didn't write it, it didn't happen. Don't make stuff up, of course. And then also just making sure that you line everything up and that it makes sense for the next person who might read the chart behind you or the notes behind you. Just be descriptive. So I see a lot of the nurses that I work with, their charts, and they document, medical stuff. So theirs probably don't need to be as wordy as the social workers. But sometimes when I look at the nurses, and this is just talking about as a discipline, nursing notes are not as detailed as social work notes from what I've seen. Even though I work with nurses who are case managers, some of them don't put as much detail, and some of them even wait for me to do my note because they know it's going to be thorough and they know it's going to be detailed, and then they try to copy and paste. But I've had a colleague before who would always wait for me to do my note, and we had this case where it was it was a case where our records could have possibly been subpoenaed for court, and the nurse wanted to know about doing a mandatory report to Adult Protective Services, and she didn't know what to do because something happened on a Friday, and then she didn't address it until Monday, and she was in a panic, and she called me, and she didn't know what to say to the patient and the family. And so I told her to just, let's make a call together, a conference call, and talk to them together. And then when we got on the phone, she took the lead, and because I told her what to say. Some people just, nurses and doctors and teachers and firefighters and clergy people and pastors, we're all mandated reporters. And so it's important that when you work with your colleagues and other disciplines, that they know that they are also a mandated reporter too, and that it's not really good for them to try to pass the buck to you to make a report with them giving you secondhand information. So if someone knows information directly from a client or a patient, and then they tell you that information with the intention of you making the report, put it back on them, because you don't know what happened firsthand. You're getting secondhand information from your colleague. And so, stand up for yourself and say, I respect the fact that you trust me enough to make this report, but I don't feel comfortable making a report with secondhand information. And since you got the information firsthand, I think it would be better if you made the report, because you're also a mandated reporter. And some people might feel some kind of way about it, but it's the truth. I mean, I've had a doctor ask me to make a report based off information the doctor told me about a patient, and I didn't feel comfortable doing it because I didn't know what was going on, and I knew the kind of questions they were going to ask when I called to make the report, and I didn't have enough information to answer those questions, and so I declined, and the doctor decided that we would wait and work together, and then at a later time, when we got like a few weeks later, we gathered more information, and then we both made the report together. So it could even be that kind of thing where you work together to make a report. But anyway, back to the documentation part of it. The nurse that I was working with who didn't know about the mandated reporting, I told her specifically because she was the one who would always wait for me to write my documentation. And because of the sensitivity of the situation, and because, again, our records could have potentially been pulled because of the situation, I told her to make sure that she documents her note from a nursing perspective, and that I was going to document my note from the social work perspective, because it was very important that the medical information was in the chart, and from that phone call, and from the incident that happened on that Friday, and from the phone call we made on that Monday. And she didn't do that. She still did not. She still waited for me to do my note, and she just copy and pasted and just changed a few words. And so I was like, okay, whatever, I'm covered because this is clearly my social work note, but she didn't write it from her perspective. And I just feel like if we were ever to be subpoenaed to court for that situation, she would not be prepared because she didn't want to just write out a note, a detailed note, because sometimes, you know, you can jot something down really quickly, but when you have a situation like what she and I had, it was very vital that we documented very thoroughly on this note, because it had to do with the patient being depressed and saying they were going to take medication and all this other stuff. So anyway, make sure you hold your colleagues accountable for their documentation as well, because you never know when your records are going to be subpoenaed, and you want to make sure, because you work as a team with your colleagues, that everybody is on point. So that's all I have to say about the documentation. As far as self-disclosure, and let me just check Facebook and see if anybody is on here, see if anybody has any questions on Facebook. Don't see anything on Facebook, so we'll switch back over to YouTube. Oh, wait, so something was on here. Oh, Myra is on here. Hey, Myra, if you're still here, hey. So me and Myra, y'all know Myra's one of my best friends. We went out on, well, Myra, do you mind if I tell the story? We went out on Friday night for dinner, and we had an incident that really concerned us that we saw. I don't know if she's still on here, but I'll wait to see if she responds. But anyway, so I might tell y'all a story about what happened when me and Myra and one of our other good friends went out for dinner on Friday night. But so about self-disclosure, though. So self-disclosure, of course, and I'm just explaining this because I know, like I said last week, there are people who are still in graduate school learning to become a social worker, earning their degree. And so I know most of us already know about, documentation, self-disclosure and stuff like that, but some are still learning and some just don't know. So self-disclosure, of course, is when you are in session, whether it's case management or assessment or therapy with the client, and it's a tool that you can use to help build a rapport with the client, but you have to know how to use it. So self-disclosure is when you tell your client or your patient something about you in order to kind of relate with the patient or the client to build a rapport. So they always advise that we don't use self-disclosure frequently, that we don't use it a lot. I hardly ever use self-disclosure when I worked with adults primarily, because, they're adults and you're going to build a rapport with some people and some people you just won't. I'm not saying that I've never self-disclosed with an adult, but I just didn't use it as frequently as I do now with the teenagers that I work with, because I work with children with type 1 diabetes. And so I'm 32, and again, these kids are teenagers, so I want them to, most people say I look younger than I am, so they kind of do open up to me more and they trust me more. Um, I've had patients ask me to talk separately from their parents and stuff like that. So building that rapport with a teenager, sometimes you have to, kind of meet them where they are and remember when you were a teenager. And sometimes I self-disclose certain stuff about myself in order to get this child to open up and to build a rapport with the child. So that's really the only time I use self-disclosure. So if a patient tells me that, because I work with children with type 1 diabetes, so that's the primary reason that they are patients, but they also have trauma and a lot of dysfunction that goes on in the household and in the family, in their environment. And so there's more than just the medical aspect of it. So I've had patients who don't have a great relationship with their father. And so sometimes they'll come in and they don't want to talk. They just close down. And every single visit is the same way. They don't want to talk. They don't want to open up. But you can just tell, I can just tell that something deeper is going on, and they'll act like everything is okay. But when you work with the same patients for years, literally, because they have type 1 diabetes, it's a chronic condition, it's going to be with them forever. And so every 2 months or 3 months, continually, we see the same patients until they eventually turn 18 and are transitioned into adult endocrinology. So you get to know these children, and you get to know when something is wrong with them or when they're not being themselves and that kind of thing. And we also talk to them in between visits. So that's why it's ambulatory case management, because it's on an outpatient basis. But anyway, so, some of these kids, you can just tell that something more is going on with them. And so sometimes it turns into like a crisis intervention office visit, not just to learn about their A1C and their blood sugars and stuff like that. So that's why I go to the appointments with them, because I need to see, are they going to therapy? Do they need therapy? Are they doing well in school? Do they need a 504 plan? Do they need an IEP meeting and those kind of things? And so a lot of these children don't have relationships with their parents and stuff like that. So I have self-disclosed to a couple patients, not all of them, maybe 2 or 3, where they tell me about their relationship with their parent that's not so great, and they still don't want to open up about it. And so sometimes we have hour-long office visits, right, after the doctor or the provider is finished, and we have like a crisis intervention kind of session, not session, but, time where, I might open up to them about my relationship with my dad. And then you can just tell that they kind of perk up like, oh, okay, somebody understands, but we can't make it about us. So that's where it gets tricky. So, I could tell the client or the patient, I hear what you're saying about your dad. You wish that, he would call you sometimes and things like that. And, I've gone through the same thing with my dad. So I know how you feel. So it's just very surface. So I just say something like that. And then they'll say, yeah, so blah, 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 blah. So it's just barely giving information about yourself, not turning it into it being about you, but just letting the client know that, yes, I know how you feel. I've been there as well. And so, or it could be something like maybe the social worker has type 1 diabetes too. And so that's not something that most people go around telling their patients or their clients, but, or just anybody in general for that matter. But sometimes it would be ideal for the social worker or the nurse or whoever is on the team to also relate to the patient in that way too, because if you have the same condition that I have, then I know that you probably understand what's going on with me. It's kind of like the same thing where for addictions, well, for one thing, for the exam, they always say that groups are the most effective treatment for anybody that's addicted to anything. So that's something that might come up on your exam, just to throw that out there. So the most effective treatment for any kind of addiction, be it drugs, sex, gambling, porn, or whatever, the most effective treatment is to be in the group setting. And so that's because if you do one-on-one therapy with someone that's addicted to something, it can be effective, but the most effective is the group setting because everybody has the same issue or challenge and can probably relate to the other people in the group, and they don't feel judged, and they don't feel they don't feel judged. And they also feel like other people can call them out if they're in denial or if they're BSing everybody. And everybody can just relate, and it's not a judgmental environment. So that's why they say that the group setting is the most therapeutic and the most effective treatment for any kind of addiction. Now, if you look at individual treatment for an addiction, let's say about say you're addicted to some kind of narcotic or some kind of drug or substance. And let's say that your therapist is not someone who is, well, let's make it specific. So let's say that someone is addicted to drugs, cocaine or something like that, and they are going to NA. Well, no, let's make it alcohol. Let's make it simple. So let's say that somebody has an alcohol addiction and they go to an individual therapist and they ask the therapist if he or she is in recovery too, and they say no. So this person might feel like the therapist can't relate to them. And the therapist doesn't have to disclose whether or not they are, but the client might feel like the therapist can't relate. And so maybe that's not going to be effective for them because they think that the therapist can't relate and they don't want to open up. But if you send them to AA, or if you give them a sponsor who is also in recovery, they might feel like this person understands me and this person knows what I've been through. And so it's just more effective than having to deal with, the client exposing all of their challenges to the therapist, and the client just not feeling like, or the client feeling like the therapist can't relate or can't understand because they've never been through it. And so that's why it's important to use self-disclosure in a way that the client can relate to in order to build a rapport. So that's pretty much all I want to say on that. Let's see. What else did I want to talk about? Self-disclosure, documentation. And for those of you who are just joining because I'm seeing the number go up as I'm talking, you can watch this back. I talked about documentation in detail at the very beginning of the video. But let's see. Anything else about self-disclosure? Just, make sure you don't make it about you. I think that's the most important thing. I'm in therapy now, and my therapist will self-disclose throughout our sessions. And it doesn't bother me at all because, it's letting me know that she can relate to some of the stuff that I tell her about. But sometimes people don't want to hear about your stuff. So you have to make sure you watch the client and see how they react to your disclosing, because they might get annoyed. They might be like, why is this lady telling me about her dad? Why is she telling me about, her addiction to whatever she was addicted to or whatever? They might not want to hear it. So if you have to be able to kind of gauge where your client is. And that's why it's important that we don't use self-disclosure frequently, because it's not about us. And then sometimes the client don't want to hear that. So just make sure you know when the right time or when a good time is to self-disclose. And you also don't want to again, make it about you and get into that whole counter transference and transference, where you start seeing the client as someone that has served a dysfunctional purpose in your life, or the client starts seeing you as someone that has served a dysfunctional purpose in their life. And so that's why we kind of say, just stay away from it and only use self-disclosure when you deem it necessary. So I am continuing on with the cognitive process therapy training that I talked about last week. So hopefully next Sunday Social, I'll be talking about that a little bit more. I was going to talk about the id, the ego, and the super ego tonight, but I think I've already talked about that in the Sunday Social before. So if anybody wants to know more about the id, ego, and super ego, then check out some of the previous Sunday Socials. Or if you want me to talk about it next week, then I can. Of course, the id, the ego, and super ego. The id is is the pleasure principle. The ego is kind of like the balance between the id and the super ego. And then the super ego is about perfection and delayed gratification. The id is about instant gratification and that kind of thing. So the ego is in the middle, and it kind of regulates the id and the super ego. So that's just a brief little thing on that. What else? So I think I'm going to end up deactivating my Facebook account, which means that I won't be able to do a lot on the Facebook page. So I started last week with kind of trying to unplug because there's too much going on in my life right now. So I've been trying to stay off social media, stay off Facebook, Instagram, YouTube, and all that other kind of stuff. But I do know that I do have to approve people when they request to join the Day-to-Day Social Work Facebook group. So I've been just going on there daily and just approving those people and then getting back off. So I'm probably going to do that again this upcoming week, just because I don't want anyone to not be able to get into the group if they have something they want to post or say or whatever. Or if they don't want to miss the discount on Fridays for the 45-day pre-recorded tutoring series. But I might end up just deactivating it for the week and then approving everybody at the end of the week. But Myra is also an admin in the group, and she can also approve people for the group. And let me just see if Myra ever responded. Natasha McCoy, hi, welcome. This is the first time watching you or your videos. Where do you recommend I start studying if I use your system? Leander Wells, thank you. Okay, so Natasha says that this is her first time watching the videos, and she's asking where I recommend that she start studying if she uses my system. So with Day-to-Day Social Work, I have the YouTube channel, which is over 100 videos on helping you prepare for the exam. I have videos on just social work in general, just review material on the Code of Ethics, on Piaget and Erickson, and just a whole lot of stuff. I have the Sunday Socials that have a lot of information that can also help you study for the exam. So I would always say to just start with the YouTube channel and browse around and see if there's any videos there. I've been getting a lot of comments lately where people who, even if they don't tutor with me, they will use the YouTube channel to prepare for their exam, and they'll let me know in the comment sections on the videos that the videos were very helpful for them, and it was a very big part of them studying and helping them pass the exam. And so if you look on the videos and look in the comment sections, you will see comments on different videos about how it was helpful for them. I actually had a lady that reached out, and she said that the videos were helpful for her, and she sent me a little donation this week. So I'm very appreciative of her for that. She said she wanted me to have lunch on her. And so her name was Ebony K on YouTube, I believe. So thank you for that, Ebony. And I'm not saying that, to solicit anything, but she just wanted to do that out the kindness of her heart. So I appreciated that. But, people will tell me all the time in the comment sections that the videos were helpful for them while they were studying for their exam. So start with the videos, and then I always tell people, try to pass the exam on your own the first time without buying a whole bunch of stuff, without getting tutoring and all this other stuff, because it is possible for you to pass the exam without paying hundreds and hundreds and hundreds of dollars on this book and this package and this and this and this and all this. So it's possible to pass the exam the first time on your own without putting a whole lot of money into the exam. Now, there are some people who say themselves that they aren't good test takers and they would prefer to have tutoring. And so they don't really, it's no big deal for them to pay for some kind of package or material or boot camp or whatever. But I always encourage everybody that listens to me to try it on your own and without spending all kinds of money on it, because it's possible to pass it on your own. Now, if you happen to go and you don't pass it and you feel like you need help, then I would say after you utilize the videos on the YouTube channel, and then you want to do some tutoring. Now, with the tutoring, I'm not doing any one-on-one live tutoring until further notice because of all the other stuff I have going on. But I do have the 45-day pre-recorded tutoring series, which is literally the same exact thing as the one-on-one tutoring. I just recorded it so that I could reach more people, since I'm the only one that does the one-on-one tutoring. So I just recorded everything. I've addressed all the questions that most people have because I've kept trends of the questions from my live sessions. And so when I recorded the videos, I made sure to address the questions because most people have the same questions. And I've tutored people all throughout the country and 2 people in different countries as well on a one-on-one basis. But I always say to start out using the videos, trying to pass it on your own without any heavy investment and spending money on tutoring and all this other stuff. But like I said, if you feel like you need tutoring after you, and we always claim that you're going to pass it on the first try, but we're also realistic. And in the event that you don't, then yes, do the tutoring. 45-day pre-recorded tutoring series every Friday. There's a discount for new members to the Facebook group. And I also have specials on it throughout the year. So the point of the tutoring with me with day-to-day social work is to help you understand how to take the exam. So all the videos on the YouTube channel are free. It's content review. It's stuff that you can look in your book or look at other YouTube videos or look at Google or whatever and find. So it's no point in charging somebody to do, let's see, I did that the first time and didn't pass, and the second time I had to take it because my year mark. Scroll down and see. My year mark had. See, this Facebook thing doesn't let me scroll, so I can't see the rest of your comment. But yeah. So the pre-recorded tutoring series is literally the same exact thing as the live one-on-one. But it's 15 videos covering over 180 questions over 11 hours. And it's literally you and I, it's recorded, but it's me sitting there reading every question aloud and breaking everything down and pulling out the relevant information, tying everything back together, showing you how to use the process of elimination, showing you how to pick between your 2 remaining answer choices, showing you how to tie everything back to the tie everything back to the scenario and then pick the best answer. And it's about learning the strategy, because I've had a lot of people who will say, I graduated grad school with all A's. I was at the top of the class. I had a 4.0 GPA and I still failed the exam, or I've been in the field for 20 years and I failed the exam. None of that really correlates to the exam. So you can be the smartest person in the world, you can have all the experience in the world, but you have to know how to take this exam, because it's not where you can just read it like you do in school and then regurgitate the information back. It's about application, and it's about like being the perfect by the book social worker, knowing how to answer the questions, how the test writer wants you to answer the questions. And that's what I teach you in the one-on-one tutoring sessions. And also in the 45-day pre-recorded tutoring session. So let's see, I did that the first time and I didn't pass. And the second time I had to take it because my year mark had approached and I had to take it per the social work board and did better without studying. So now I want to study with videos and audio with material. Right. So, and also people learn differently. So some people are audio, some people are visual learners, some people are auditory learners, some people are kinesthetic learners. And so, you know, if you are an audio visual kind of person, then videos might be more, they might be better for you, or writing out your notes over and over might be better for you so that you can see it written down, you can write it. Same thing if you're a kinesthetic learner, where it might be better for you to write your notes and have flashcards and that kind of thing. So but yeah, I always tell people don't study for too long. Like to me, just in my opinion, 3 months max. You don't want to study for 6 and 7 months because that's dragging it out. Like you need to have a very succinct study plan and stick to it. You don't want to sit down and study for more than about an hour and a half, 2 hours max at one time. So you don't want to just study for 4 hours straight because people don't retain a lot of information that way. So, you know, I always tell people start with the KSAs too. So make sure you have a copy of the KSAs because some people get overwhelmed. They don't know where to start, especially if they've never taken the exam before. The KSAs are the knowledge, skills, and abilities, and it's an outline of what to expect to be on the exam. It's a good place to start. I always tell people to print it out and then mark through the stuff they already are familiar with, and then highlight the things that they aren't familiar with so that they can kind of have somewhere to start as far as studying. And KSAs are what could potentially be on the exam, and it's broken down into the 4 different sections on the exam. Let's see, let me switch back over to YouTube and see if anybody has any questions here. No. Okay. So yeah, that's what I would say. Since this isn't your first time doing it, just make sure that you continue to review. Of course, I always say the strategy is the most important thing to know on this exam, but that's not to say not to study the content, because it is important to study the content. For over the last year and a half, people have been reporting back that the exam is heavily based on community social work and school social work. So I also would make sure to study those 2 areas before taking the exam. What else? You know, look on the YouTube channel and see the testimonials from people who use the 45-day pre-recorded tutoring series to learn how to take the exam, learn strategies, new strategies. And if you want to take advantage of that, then let me know. All right. Anything else before I get off? And Myra's not on here anymore, so I don't know if she wanted me to tell y'all the story about what happened when we went out to dinner on Friday night at Joe's Crab Shack. But I mean, it's nothing like confidential or anything, but she's not on here, so I won't tell the story. But all right, so I will see y'all next Sunday social. As always, my email address will be in the comment section. The website will be in the comment section. The YouTube and Facebook will also be in the comment section. So you can contact me at any time. I try to answer you back very promptly within a couple hours. If not, then definitely by the next day. So happy studying. Thank you for the work you do, as always. And I hope y'all have a great week. And, you know, if you watch the videos, any of the videos on the YouTube channel, give me some feedback in the comment sections. It doesn't have to be anything long or lengthy, but, you know, just give me some constructive feedback. And I like to hear from y'all, and just let me know what y'all want to talk about in the Sunday socials. But until next time, I will see y'all later. Have a great week.